Today I'm presenting a project entitled Effective Metformin versus DPP4 Inhibitors and Sulfonylureas on Surrogate Type 2 Diabetes Outcomes. Historically, metformin has been avoided in patients with type 2 diabetes and chronic kidney disease, or CKD, due to concerns of an increased risk of lactic acidosis. We used propensity scoring in Figure 1 to demonstrate that patients with lower baseline GFRs, or glomerular filtration rates, are in fact more likely to be prescribed DPP4 inhibitors, and conversely, patients with GFR greater than 60 are more likely to be prescribed metformin at present. Despite the FDA's recent easing of recommendations against metformin use in those with CKD, it remains unclear what the optimal anti-diabetic therapy is and what the effect of different diabetic drug classes are on surrogate type 2 diabetes outcomes in this population. Consequently, providers are operating in a state of clinical equipoise, as demonstrated by Figure 2, which shows that there's a significant number of patients in our sample who are found to have intermediate propensity scores, meaning scores closer to 0.5 in value than to 0 or 1, indicating that these patients were equally likely to be prescribed either metformin or DPP4 inhibitors. In light of this, we investigate the effect of metformin versus both DPP4 inhibitors and sulfonylureas on GFR, hemoglobin A1C, and BMI among a cohort of patients with type 2 diabetes and moderate to severe chronic kidney disease. This study was a new user, active controlled retrospective cohort study of Medicare patients with type 2 diabetes and CKD who received healthcare at one of several major New York City academic hospitals and were initiated on either metformin, DPP4 inhibitor, or sulfonylurea, regardless of background use of other diabetic agents. Inclusion criteria required the patients be age 18 or older, have an ICD-9 or 10 diagnosis code for type 2 diabetes, or a hemoglobin A1C greater than 6.5 prior to a first prescription of one of the drugs of interest, be a new user of these drugs, and have a baseline GFR of less than 60. Individuals were followed for 270 days after the index date and censored in the event of death or Medicare disenrollment. Follow-up GFR, hemoglobin A1C, and BMI were determined by averaging all the available data between 90 and 270 days after the index date. We identified 240 metformin users, 305 DPP4 inhibitor users, and 191 sulfonylurea users. We found that compared to DPP4 inhibitors, metformin use was associated with statistically significant reductions in hemoglobin A1C and BMI, but no significant change in GFR. Subgroup analysis of the metformin versus the DPP4 inhibitor groups, stratified by GFR range, suggests that DPP4 inhibitors are associated with a significant increase in GFR for patients who have a baseline GFR less than 30. Primary analysis yielded no significant difference in GFR, hemoglobin A1C, or BMI when comparing the metformin and sulfonylurea groups. Nor were significant differences seen within GFR subgroups, except that sulfonylurea use was associated with significantly higher hemoglobin A1C in the subgroup with a GFR between 45 and 59. We conclude that for patients with type 2 diabetes and chronic kidney disease, metformin appears to be superior to DPP4 inhibitors, as it offers greater glycemic control, appears to have comparable effects on weight, and results in no significant decline in renal function. That the sulfonylurea and metformin groups did not differ significantly in change in hemoglobin A1C suggests that in patients with type 2 diabetes and chronic kidney disease, metformin offers similar hemoglobin A1C reduction without the risk of hypoglycemia associated with sulfonylureas.